So without further ado, let me just introduce Richard. So Professor Richard Huxtable is Professor of Medical Ethics and Law at the University of Bristol, where he's the director. His research primarily focuses on legal and ethical issues in end-of-life decision-making, surgery, and paediatrics. He's the author of multiple books. I'm sure you can all easily Google him and find out more. And of course, his research is being funded by many prestigious bodies, including the Wellcome Trust and European Commission. Richard's a good friend of the Center for Biomedical and the Center's program, actually. I remember when we first arrived, we first came maybe 12 years ago or something. But anyway, without further ado, please join me in welcoming Professor Huxtable to the...
Thank you very much, Sumi. Can you all hear me? Yes, wonderful. So wonderful to be here. Actually, my link to the Centre for Biomedical Ethics and indeed centres goes back to 2006, which makes me feel incredibly old. But we'll move away from that. It is wonderful to be here. Thank you to Sumi for the invitation, to Fionn and the team for all your help with everything, and thank you all for being here. So what are we talking about? Well, we're talking about surgical innovation, hence the headline title I've chosen, very much a pun, at the cutting edge. So cutting in the sense of we're talking about what surgeons do, but also that metaphor of cutting edge new technologies and the like. Wonderful, thank you. So I should say thanks to colleagues at the University of Bristol, some of them named on this slide, and indeed to the NIHR, which funded a whole package of work we're undertaking in Bristol involving colleagues in ethics, but also surgical colleagues as well. But of course, anything I say today will be very much my own views. So what will I be saying? Well, I'm going to explore 4 questions, and they are briefly stated: what is surgery in the first place? What makes it permissible? So legally, what makes surgery acceptable? Then moving from that background, what is surgical innovation and what makes that legally permissible? And you might think, indeed you might yourselves have easy answers to all of these, but I should say that a great many of the remarks will be from my background in English and Welsh law, but hopefully some of the issues I raise will have wider relevance, particularly to you in Singapore. But my headline answer to all 4 questions is as follows. Don't really know. I think all 4 of them are rather unclear, rather obscure. So I'll mainly spend my time explaining why I think they're obscure, but I will try and offer some suggested answers where I have any, and I'll be interested in your reactions to those suggestions. So if we kick off most briefly with what is surgery, you might well think, and in fact, quick show of hands, are there surgeons in the room? So we don't have any surgeons in the room. But I was going to challenge any surgeons here to tell us what they think surgery is, so that's probably a good thing. We'll move on. But you yourselves, even though you're non-surgical, will have a view on what surgery is, and yet, and this is from colleagues in Bristol, Sian Cousins and colleagues, there is a feeling that actually it's not a terribly precise concept, or indeed beyond concept definition, if we talk in terms of surgery or more broadly invasive procedures. One can certainly look on the left to what the dictionaries say, so they will point out features you might have in mind, such as using instruments in a healthcare setting, typically to cut or similar, do something invasive to the body, as indeed another Bristol colleague, Gordon Stirratt, who indeed set up our ethics centre, he pointed out that it is an invasion of the patient's bodily integrity. So we're starting to get a sense of what surgery is, but it's rather woolly. It's instruments, it's probably cuts, it's some sort of invasion. So our colleagues, Sian Cousins and co, on the right-hand side, attempted to come up with a more precise definition, particularly for research purposes. They wanted to be able to identify surgery, to review and evaluate surgery, and indeed to inform future studies of it. So they offer, and I'll just focus on the top part, a definition that includes purposeful or deliberate behaviour that involves incision, so cutting, puncture, and/or some sort of insertion through a natural bodily orifice. So that's what they have in mind. Essentially, if you step back, incision or insertion. And that, if we then look to colleagues in Oxford, DeMarco and colleagues, is what you might think of as a quite standard account of surgery, or more broadly, invasive procedures. And they then move to look at invasive procedures, and more generally, and say, this incision-insertion idea misses part of the picture. And in fact, they think it misses three parts. So one is the fact that when we apply the label invasive, sometimes it's in relation to a matter of degree, it's scalar. In other words, we're using the word invasive to contrast it with something non-invasive. So that's an important feature, they think. The second is context does matter. So you might be more or less invasive, and indeed you might be more or less invasive relative to something else. And then finally, it might not, contrary to Gordon Stirratt's view, only be bodily invasion. There might be invasion beyond the body. For example, psychotherapy might, in some instances, be considered invasive. So they're starting to work towards an account, and I won't talk to all the detail here. I'll do this elsewhere on the slides as well, but we can come back to it if you like. But they're starting to work towards an account that tries to distinguish between degrees of invasiveness, different thresholds at which we consider something invasive, whether in itself or compared with something else. Cousins and colleagues were looking at this because they thought it was important for research. DeMarco and colleagues think it's important morally to work out what counts as an invasive procedure. But the real question I want to drill most into is the legal or permissibility question. So in other words, I think whether something counts as surgery matters legally, at least in our legal system. And I raise it as a question for you, whether it's also relevant to your legal system. I suspect it is. There we are. So what is it that makes surgery permissible? Well, I'll very briefly give you some criminal law from back home. I'm sure you have similar offences against the person here. Two of them we don't need to really study because they don't apply for two reasons. One is a medieval offence, so very long history of maim or mayhem. Our senior judges have said that is no longer an offence that applies, so ignore that one. The other one to ignore is the very low-level offence of common assault or battery. I did not clear this in advance, but I'm illustrating common assault or battery right now by simply touching Sumi on the shoulder. That's it. She did not consent, so I theoretically committed an offence, but that's back at home, so I hope I'm okay. I'll move on. And I won't illustrate the other offences because things get much more serious. So we also have actual bodily harm and grievous bodily harm and offences of causing grievous bodily harm with intent. So there's a whole package of criminal law offences in the background that involve some degree of at least bodily, but perhaps beyond bodily harm, which you might think in theory a surgeon commits. But you might think it only in theory because the reality is surely for everyday surgery, they're not being called before the courts to defend their actions. With at least one, in fact more than one, but at least one recent example back home that proves the exception. This is Ian Patterson, a notorious breast surgeon who was found guilty of various offences against the person for essentially mutilating surgery without appropriate consent. So he was actually sentenced to 20 years in prison. I'm not going to be speaking more about people like Patterson. What I'm really focusing on is not the rogue outliers, but rather everyday surgery. What is it that makes that lawful? And in fact, that question can be asked of a range of other behaviours, some of which are lawful at home, others of which are not. So there are also questions being asked by our legal scholars about series of so-called problem areas. I'll give you a couple from the slide. What is it that makes violent contact sports lawful? Boxing, for example. Why is that somehow lawful? Why doesn't it commit one of those offences against the person? Equally, what about my participation in non-therapeutic research? There's no chance of benefit to me. It might benefit other people, but it might actually involve harms to me. Why isn't there a crime being committed there? I'll hypothesize, on the basis of conversations I've had with various colleagues and friends in recent months, that if I were to ask you, if we go back to our central case, top left, everyday surgery, what is it that makes surgery every day lawful? I think I know what answer you'd give, but I'm going to ask Sumi to give me a one-word answer. What makes everyday surgery lawful? Consent. Do we like that answer? Some of you are smiling, others are not too sure. I'm with the not too sures because it is only part of the answer. So consent is definitely an element of it. And if not consent, then some substitute for consent, a proxy consent, an advanced decision, a decision in someone's best interests or similar. But consent is kind of your gold standard. But certainly if we look to the Law Commission, which at home is the body that looks to reform the law, make changes to the law, it is said quite explicitly that consent is a necessary part of the defence that makes surgery lawful, but it is not sufficient. There's some missing ingredient. So the question is, what's the missing ingredient? And here we fall back on a concept that the judges have spoken about a great deal, but I should emphasize, without really defining what they mean by it. So if we go all the way back to 1981, in this case, you have the judges saying consent is an important element of the immunity, for example, for our surgeon, but it needs more. And what they talk about is the particular intervention or invasion being in the public interest. And that's notoriously a woolly concept. But they've got in mind some idea that your invasion of, let's stick with bodily integrity, is for a good reason. They don't always spell out what the reasons are. But you certainly have them saying, well, really it's for the courts to decide what counts as a good reason or in the public interest. And their account of what's in the public interest might change over time. It might change with different contexts in relation to boxing or tattooing or piercing or surgery. We could try to flesh out the concept of the public interest, and the philosophers amongst you might have views on what we should consider to be in the public interest. Amongst the different theories out there are, you look to pull together everything that's in the objective interests of everyone. Well, an immediate response to that would be, who gets to say what's in the objective interests of everyone? Secondly, and alternatively, you bring together the preferences of the majority of people. Well, that's okay, but what about the views of the minority? Or thirdly, an alternative view would be you look at whatever we have in common as common interests. But again, you might say, well, what is that? Who gets to define what's in our common interests? So there are some big philosophical head scratchers there. But the main thing to say is, so far, at very least, the courts themselves are not really nailing down what they mean by public interest. But they do sometimes introduce an additional term. There we are. And that additional term is proper medical treatment. So the logic goes, you need consent, but you also need the behaviour to be in the public interest, and it's in the public interest if it counts as proper medical treatment. And certainly Lord Mustall, on the left there, is a judge who's advanced this view, particularly in two leading rulings back in the 1990s. That, of course, raises the next question, well, what counts as proper medical treatment? And again, they don't really spell that out. So what I'm going to try with you is my attempt to bring some clarity to this, but it's very much my attempt to explain what I think the judges are saying. It is not officially what the judges are saying, I should emphasize that. It's my attempt to explain it. Because the background problem, as Tracy Elliott says on the left, and Margot Brazier and Sarah Favag say on the right, is this idea of the public interest or proper medical treatment is unclear. So surely for law, we deserve a bit more clarity. And here's what I think is going on. And this is probably my most complicated slide, so I'll spend a little bit longer on this, but it's one we'll undoubtedly want to come back to in questions, see what you think. I'll park the top bit, which is the idea that the person receiving the invasion, in some sense, it's authorized for them, or, gold standard, authorized by them. In other words, the top is the consent bit. What we're really trying to understand is the next three, which I hope start to give some sense to this reference to proper medical treatment or the public interest. And I think there are three things going on. We will say that an intervention is proper if it's intended on balance to serve the interests of the recipient. So think classic medical cases of benefiting the person's health. Secondly, if it's undertaken or provided by a responsible person in line with responsible practice or opinion. And finally, if this type of intervention is recognized as intending to serve the interests of the public. So it's those three conditions I really want to focus on. I think, personally, this is my attempt to explain, remember, just explain what I think is going on. I'm not trying to justify. So you might critically say the law has got it wrong, but I'm trying to understand what the law's doing. And I think what it's doing is it's saying those three things, such that your paradigm case on the bottom left rather, is surgery. In the classic case of surgery to benefit the patient's health, that's recognized as socially valuable. We recognize the value of healthcare. That's your paradigm case. It's in the public interest. It's proper. With all the others, the other three conditions, you can either meet them quite strongly or fairly weakly. And the weaker it gets, the closer you get to the line that says, actually, now what you're doing is improper. So there is an example of that on the far right. That one is a very controversial ruling from the 1990s. It involved something quite unlike surgery. It was homosexual, sadomasochistic sexual practices involving piercing the skin and more. I won't go into the gruesome details. The judges thought this was improper. Now, they might be being very prejudiced in that decision, but that's what they thought. In the middle, however, if you go to clearly, you do, of course, have situations where you don't reach the gold standard of consent. Let's say a proxy consents to surgery on the patient's behalf. But otherwise, all the bottom three conditions are met, and it looks like this is clearly proper. We still want patients who lack capacity to be treated in their best interests, for example. We get closer to the borderline between the two in some cases. And one of those cases I would suggest is non-therapeutic cosmetic surgery. Our judges clearly have some discomfort with this. They recognize it's lawful, but at the same time, they kind of signal we're a bit uncomfortable. This doesn't look like therapeutic surgery, in other words. As I say, we can come back to this, but I think those three conditions start to cash out what the judges mean by proper medical treatment. Something about benefiting the person receiving it, about it being the right person doing it according to the right standards, and that the intervention itself is recognized as socially valuable by the law. Okay, where does that take us? Well, it takes us still to the proposition that we're still not absolutely settled on what surgery is. We have a sense of it, but it remains a little ambiguous. And I think if, depending on your views on my account, there's still some ambiguity in what the law is saying about what's lawful, what's unlawful. So that's not terribly helpful. Unfortunately, things get more complicated once you move to our main focus, which is what is surgical innovation. And I think, and we have a great many conversations about this back home, and I see them occurring internationally, there is a sense that when we talk about innovation in healthcare, and certainly surgical innovation, this is something that's positive. The word carries, if you like, positive baggage. We think innovation, that's new, that's shiny, it's intended to benefit people, that sounds like a good thing. But we also know, including allegedly from the use of the Da Vinci robot, that there can be instances of harm coming to patients in some instances of innovation. So innovation might sound positive, but it won't always be positive. So I sometimes think we need a word that doesn't have all the positive baggage. Here's my suggestion. A word like newfangled gives us a slightly more negative take and maybe raises our sense of risk. But I'll stick with the language of innovation. How am I for time? Excellent, thank you. There we go. So I'll stick with the language of innovation because that's very well established, and indeed that's the title of the workshop, so it seems appropriate to do so. What's the issue? Well, one of the issues, particularly if we're trying to pin down what surgical innovation is trying to distinguish it from some other things with which I think it often overlaps. So on the one hand, far left, you've got treatment, or if you like, standard treatment. I'm just using a dictionary definition there, something to cure illness or injury in a healthcare sense. On the far right, you've got research. Something, and this is an official definition of research back home from the Health Research Authority, something about generating generalizable or transferable data or information using scientific methods. Innovation falls somewhere in the grey area and is much harder to pin down. And so we have, again, Margot Brazier and Sarah Favag, two academic medical lawyers back home, commenting that actually what they see happening in healthcare is what counts as innovation or surgical innovation is whatever the doctors or surgeons say is surgical innovation as opposed to standard treatment or research. So the doctors get to define what counts as innovation. And indeed, that is a strategy that's been adopted in one of the most widely known protocols or policies out there for trying to identify and respond to surgical innovation. This is the Macquarie Surgical Innovation Identification Tool. So you have Hutchinson, Rogers, and colleagues suggesting that innovation is all about doing something new, where the newness is defined by the surgeon themselves, and the newness might relate to the device or the technique or the patient receiving it or the indications for which it's given, or indeed the anatomical location in which the procedure is occurring or the device is being inserted. Now that sounds well and good, and they did base this on some robust research, but my colleagues and I, Giles Birchley, Jonathan Ives, and myself, on looking at this, felt there were a few problems with it. I'll just briefly summarize them. One is, it only captures planned, prospective innovation. And we know from some of the data that's out there and the anecdotes we hear that sometimes innovation occurs in the moment in an unplanned way. So it only captures part of the story. It also still feels quite vague. It still feels as vague as the word innovation itself. Now you just are asking, well, what counts as new? It could also be seen as a burden on surgeons because now the job of identifying when surgical innovation is occurring is a job of the surgeon. They're not being given guidance on when to spot it. They're being told, you spot it when you spot it. And of course, if it's about you spotting it when you spot it, then people's views on this will differ. So you end up with subjectivity and variability. And indeed, there may be risks, including to patients, because we know also, with great respect, that some surgeons may be conflicted. They may have an interest, a personal interest, in doing the new procedure. They will gain finances, they will gain in their reputation. So perhaps this tool doesn't do all the work of helping us pin down what surgical innovation is. So we ourselves as a team, Giles, John, and I, attempted to try and capture the concept of surgical innovation by trawling through databases and particularly focusing on 72 papers. And we identified from the basis of that 5 features of surgical innovation that relate to the reason why it's occurring, And it will usually be a response to perceived unmet need, probably the unmet needs of the patient, but it might be the needs of the surgeon, rightly or wrongly. The place, and there we noted it's very broad. It could be in a standard treatment type setting, but with some variation, or it could be occurring within a research protocol or trial. So it occurs in lots of places. It also results in things that essentially is something somewhat new in some sense, deliberately ambiguous, but with certainly risks that may not be known, certainly at the time that you're doing it. It might occur through a systematic process, but it might also be quite chaotic, haphazard, unsystematic. And finally, it's the person themselves who gets to determine whether they're doing it, how they're doing it, and so on. So what we actually concluded, rather controversially, but almost classic philosopher approach really, was this whole term surgical innovation isn't really helping anyone, because it could refer to lots of different things at any given time, such that we're not really nailing down what we're really concerned with. So we suggest maybe we should get rid of the term. We recognize in truth you're never going to get rid of the term, keep the term, but become more specific about what it is you want to identify and what it is you want to regulate and how. So if, for example, just to take the easy example, if we're concerned about risk to patients, come up with a regulatory scheme that can best address risk. Whether you call it innovation, treatment, research, if it's all about risk, let's regulate for risk. Let's not call something surgical innovation when it's very broad and quite ambiguous. So the hardest bit is this last bit, which is, well, given all that, where are we in legal terms then with surgical innovation? And as a way into this, I'll give you probably the most famous model for thinking about surgical innovation, which is IDEAL. So IDEAL conceptualizes the different stages of innovation, and in the fourth column, gives you an indication of some of the regulation and processes we'll need to hopefully ensure it's most safe. So broadly, they talk about you start with an idea that might involve very few people, both as receivers and as givers. You then move to development and exploration, where the numbers get bigger. Then you move to assessment. And finally, you move to long-term study. Now, we also had some qualms with this, and I'll just briefly mention them. These were drawn from other literature, but they include that this, again, looks very broad, and it can be sometimes quite hard to decide which phase you're in. How do you distinguish which phase you're in and the appropriate response to the phase? And query whether it was or is entirely practically useful. But we do know it has international uptake. So we're not necessarily saying get rid of it, but rather my reason for raising it now is to go back to that question of where does it fit on our different bubbles. And the stages of IDEAL, I'll suggest, actually map onto different bubbles at different times, which has relevance right at the top to the question I posed earlier about what makes treatment or any intervention proper. And here's my current thinking on this. If we start from the bottom of IDEAL, then once we're into the area of long-term study, we're really talking about this is something that's now on the table for surgeons to select from amongst alleged accepted or acceptable even practice. So you're probably in the green area. You're probably closest to the paradigm case of reasonable surgery, everyday surgery, as I expressed it earlier. In the middle three phases, development, exploration, assessment, notice that they talk very explicitly about seeking research ethics approval, so IRBs and the like. So clearly they think that falls into the research model, where we probably are in the realm of clearly proper, provided that the research mechanisms and processes are followed. So provided you get that IRB review. We're still at a minimum at the top level, the idea where you're trying it out on a few people, you're still in the grey area. And there I would suggest you're probably right on the borderline of whether this is appropriate or proper in the first place. It probably would be accepted. There are indications from the courts they will accept it, as I'll show you in a moment. But I think you're quite close to the borderline if you're not following accepted practice or indeed accepted research mechanisms and processes. So much for the criminal law. I do have things to say about the civil law and tort law. I just looked to Sumi. How are we for time? Yeah? Okay. Shall we talk about negligence? It's a bit heavy for a Friday morning, isn't it? There's not too many smiles, but there's a couple of smiles. Let's talk about negligence. So it gets complicated, this, but hopefully I can do it fairly lightly, and then we can come back to the detail if you wish. So quick recap, but I appreciate there will be lawyers in the room, and indeed there are lawyers in the room, so this will be well known to you, and indeed you'll have your own laws on top of these familiar cases. But essentially, in negligence, let's say our surgical patient sues the doctor, claiming the doctor owed them a duty of care that was breached because the care provided was substandard, and that breach of duty caused them to suffer harm. It's the middle bit I want to focus on, the breach of duty, or the providing care of an acceptable standard. So the famous ruling of Bolam essentially says it is acceptable practice if, indeed, it is practice that is in accordance with what a responsible body of medical people in that particular specialty would do or would confirm that they could, in theory, do. So if, in other words, a body of opinion agrees that looked reasonable to us, you're okay. The courts then became a little concerned and said, well, that sounds like doctors are judging for doctors what the standard of care should be. So our courts in Bolitho said it's still ultimately the judge's job to decide what counts as proper or responsible practice. And if, in the rare case, we think that the practice is incapable of withstanding logical analysis, then the court can strike it down and say, no, that is not the appropriate standard of care. In other words, that is negligent. So how might all that apply here? So we focused quite a lot so far on the criminal law. Obviously, this area of law, in practical terms, is most likely to be relevant. I think it's vanishingly unlikely that a surgeon's going to be prosecuted for a crime, unless they're the outlier like Patterson. But the possibility of negligence might be more real. So let's look at it a bit more in relation to innovation. And indeed, a few years ago, one of our leading public figures, Lord Saatchi, after his wife sadly died following cancer, he basically said the whole negligence law is a barrier to innovation in the National Health Service. So he proposed a new law with two elements, and he called this the Medical Innovation Bill. In fact, there was more than one. But let's say the Medical Innovation Bill, two elements. The first is to deem innovation immune from a negligence action. And then the second would be to create a database so we have a national repository of where these innovations are occurring so we can gather the data. So taking them in turn, in terms of the first one, this idea that we deem innovation not to be negligent, well, there was a massive outcry. Professional bodies and patient groups and academic commentators all said this is nonsense. It's partly nonsense because it focuses too much on protecting the doctor over protecting the patient, but it's also legally flawed. It is the flawed premise because actually the negligence law does not stop innovation. And this is just one case. There will be others we can talk about, I'm sure. But this case of Sims and Sims, two patients with suspected Creutzfeldt-Jakob disease, were given an experimental therapy. And this went to court because the clinicians, somewhat understandably, particularly if you think of my point about liminal proper, they went to court to say, is it okay to give this experimental therapy? And the court said yes. The Bolam test should not be a barrier to medical progress. So, it is not necessarily the case that surgical innovation is contrary to negligence law and therefore negligent. So, the first part of the bill was struck out. So that was rejected. It didn't become law. The second part, the idea of creating a registry, sounds like a good idea. But actually, everyone said, well, you don't even need that part. Our Secretary of State for Health already had the power to create this. So why are you creating a bill to give the politicians powers they already have? Nonetheless, that did become law. However, as of certainly late last year, and to the best of my knowledge still now, tumbleweed. There has been no registry created. So we have this law that was all premised on fears that were non-existent fears, really, ill-founded fears, ended up creating a database that we don't need because we could already do that. And in fact, no one's created the database anyway. So there's not been any real legal activity on this. I think it still leaves us with questions about whether this is permissible. I think my proposition would be it is permissible, but in criminal law terms, it's just above the line of proper. In civil law terms, it's much more obviously okay. Yet, is that enough? And that's where really one of the big ethical questions arises for me. So there is this question of whether this all does enough, you might think, to protect the surgeon, but certainly does it do enough to protect patients themselves? Certainly if you think of that early phase of innovation, the idea phase. And as the Royal College of Surgeons themselves note in the middle of the slide, there's very few regulatory requirements out there on all of this. Tumbleweed, number 2. Contrast that with the left and right of the slide. If you're talking about treatment, then, as indeed on the previous slide, Ian Kennedy once remarked in the 1980s, medical lawyers have to do homework. There's lots of law, lots of regulation about standard treatments. Equally on the research side, there's lots of standards, there are lots of regulations around research, there are lots of processes. Innovation in the middle, the most we can find, there are some standards out there, I should say, but the most we can find in terms of processes to try and look at this and ensure it's as safe as possible is what are called new procedure or clinical effectiveness committees. Now, these contrast with research ethics committees and with clinical ethics committees. So they're different from that, and they're very much about, if you're using a device, but certainly a surgical intervention that is new, you go to your local hospital committee to see whether they approve this occurring. So you think, well, they've got a lot of power then to decide what happens or doesn't happen. However, the team in Bristol, and this is work in progress, so I wish I could tell you more, but this is what we can tell you at the moment. They've looked at all the policies, at least in England, in all the hospitals. So all the policies about new surgical procedures. And they've tried to work out what those policies say about what sort of authorization is needed in which situations. And the headline is massive variation in what the policies say. So not a great deal of clarity, even amongst the hospitals and certainly across them, as to when, for example, a procedure needs to go to a new procedure committee or when it needs to go down the full-blown research ethics route. Note that on the right-hand side, only 30% of the policies referred to when you need to go down the research ethics route, so the IRB route. So my colleagues do conclude that the variation, lack of clarity and contradictions basically exposes a major risk within NHS governance processes. So it's not the happiest conclusion. And indeed, this is an area that continues to be looked at. We had a major report published a couple of years ago on the back of 3 areas of experimental or innovative therapy, one of which was vaginal mesh, which certainly led to reported cases of harm for many patients. And that report noted that there have been failures of regulation, failures to obtain appropriately informed consent, and indeed failures to capture data and learn so that we can plan better and be safer in the future. So it's a bit of a downbeat ending, I'm afraid. I've basically posed 4 questions, said it's all a bit complicated and unclear. Hopefully I've offered some suggestions on what I think is going on, but I think the next step for everyone is, where do we think we should be going next in terms of regulation, safety, and the like? I will stop there. Thank you all for listening.